This is from Code Diagnostics. The ones from Real Guide look similar, but different. Actually, like I said, the graphics are better. They're going to show us every implant position, different views of the implant in the bone to make sure that we're happy. Myself and the surgeon have to approve this. We'll go on an online meeting to make whatever changes we need. And I'm just going to skip through. We don't need to look at every implant here. And then they'll also give us some renderings of the surgical guide. And in Real Guide, you can actually have your own account that you can, that Roe can download all of the planning, all of the guides, and you can actually go in there and look at them, take screenshots if you want to make presentations, but you can preserve those so that you have them in the future. Then you're also going to get a summary of all the implants that will be used, the diameters, the length, just everything that you need for the guides, everything you need to order, so on the day of surgery you're not scrambling to find something. And then you'll get a surgical recipe that tells you which drills you're going to use, the depth that you're going to go, everything that the surgeon needs to place these implants in the exact position that the virtual planning was done. Okay, so the conclusions from all of this case workup and all this virtual design were that the anatomy of the upper arch will not allow immediate implant placement. The lower arch will be surgically guided and 4 implants will be placed. And because of what I talked about before, the high floor of the mouth, the very flat arch form that they're going to have, my feeling was if I made her immediate denture, that immediate denture is just going to be moving around like a rototiller, damaging destroying the sutures. The patients can be back every day with sore spots. So I wanted to try to encourage her to consider some type of a fixed restoration that we could immediately load. So I tried again to convince her of that. She again declined and wanted to still do, the overdentures. And again, this kind of just summarizes what I just said: lack of height of the ridge, high floor of the mouth, lack of attached tissues. And so myself and the surgeon decided that instead of dealing with all the possibilities of problems occurring and the patient coming back unhappy and having a bad experience with their first incidents with us, we decided we were just going to do a screw retained restoration on the day of surgery so we could have a stable lower, and hope that she loves it so much that when we're all done that she'll say, okay, I'll do that. So it was wishful thinking, but we were prepared to spend the extra money and not charge her any money. We just kind of did it, for our own peace of mind. Okay, so now everything's planned. The implant positions are planned. The guides are planned. Now I have to fabricate an immediate denture. And so now I can extract the teeth from the model. And I can fabricate my immediate denture. And this immediate denture will be used to do an analog type of pickup with cylinders and picking up the case on the day of the surgery. And in this case, we were going to use what I showed you before, that smart conversion technique. Here's the upper denture that will just act as an immediate denture. Because the patient's going to get some bone grafting, we're going to have to pip this on that surgery day and relieve the denture in different areas so we're not pressing on the bone graft. And now here's our post-surgical radiograph. We're using Straumann's SRA abutments to retain the prosthesis. And so now we have this screw-in prosthesis that the patient goes home with on that day. This is that smart denture conversion that I was talking about. So it has a cylinder and it has this screw that holds the cylinder onto the SRA abutment. we inject acrylic into little wells on the intaglio of the denture, not holes that go all the way through. So it confines that, that dual cure acrylic. We seat the denture, hold it in place until it's set, and then all we do is we take that denture, we pop it, and the screw head breaks away from the screw, and the denture comes out, and then we drill our holes through the intaglio. So all we have is these tiny little holes coming out the occlusal or the lingual to the anteriors to retain that denture. So there's our prosthesis on the day of surgery. 3 months post-surgery, the patient loves having that fixed prosthesis, continues to decline that hybrid fee, and this was where I said to her, hey, look, I'm doing a little work with a company that has a new product that's fixed. We can do it at a cheaper rate. I offered her a $14,000 fee on it, and she finally said yes. So this is where my introduction to LOCATOR Fixed began. Okay, so she's all healed. The first step we're going to do is we're going to make her a new upper denture to go with her lower. So we're going to take alginate impressions of the upper. We're going to do a preliminary closed tray impression of the lower, because with this technique we're going to pick up the inserts, the housings in the inserts for this LOCATOR Fixed prosthesis in the laboratory. And so we start with a closed tray fixture level impression. So there's no abutments yet in the patient's mouth. She's still wearing that SRA retained prosthesis. We take the SRAs out and we screw a closed tray impression coping to the implants themselves. And now we all know, well, most of us know that closed tray impressions don't give us the most accurate impression. Splinted impressions with an impression jig give us accurate impressions, because when we pick up these inserts, we want that denture just to snap perfectly in place at the end of her treatment and not have to worry about taking out because of misfit and trying to change and re-pick up the clips. So we make this impression jig out of Duralay, and we make a custom tray so that we can get a really nice model with all the anatomical landmarks. What I use is a material called identium. I inject a light body indentium under the jig, and before we take the impression, we section the jig and then we reconnect it in the mouth, because as that Duralay's setting, it has a shrinkage and it can cause inaccuracies. It won't have a perfect fit in her mouth. And then we're going to measure the depths. So this is our master model from the impression jig. We're going to measure the depths of the tissue so we can pick out the proper heights of our LOCATOR abutments. And then we're going to screw those in at 25 Newton centimeters. Now we have to make a base plate. We have to do, sorry about that. We have to make a base plate, wax rims. We have to go to the mouth just like we're doing a denture. We're going to determine the vertical dimension. We're going to take a bite registration and centric relation. We're going to do a face bow, and we're going to do a complete mounting and setup. Again, these are things that the laboratory can do to you if you don't like to do them yourself. And because that lower jaw was so flat, just having a stable base plate was almost impossible. So when I went to try this in, I saw that the bite was nowhere close. So something moved when we took that bite registration. So what I did was went back to the cast, put some LOCATOR abutments on there, blocked out the 2 anterior locators, reamed out the base plate a little bit, and then injected some acrylic into the housings, onto the locators, seated it back on the model. So now I've created a stable base plate that's going to snap in so that I could then go back to the mouth, take a new bite record, remount the case, complete a new setup, and then have a final try-in. Now, what I noticed when I had my final try-in is that I thought maybe we could give her a little more show. I thought the teeth might have just been a little bit short, so we're going to keep that in mind as we're moving through through the case. And what I always like to do on my implant cases, and this is what I was explaining that I did on that first lady that had all those implants and we had to take her all apart. When I do my setup, I'll make a putty matrix around the teeth so that I could then take the matrix off, take the teeth off, put the putty matrix back on, so I could look at the space that I have for the prosthesis that we're going to make. Just using a little ruler, measuring how much space, buccal lingually, looking at the height, looking at the restorative space, just to make sure we don't find out anything on the day of delivery that we don't have enough space. So it's just a little tool to help you visualize how the prosthetic is going to look. And we could take one arch off and look at the prosthetic space that way, and we could take the other arch off and look at the prosthetic space. But when you do this, you find things that you really didn't see. And what I saw when I had these models mounted in that upper off is that there was really no space between that tuberosity and the retromolar pad. So if I processed that denture, that acrylic would be hitting that retromolar pad. So at this time, it was about the time that the patient was going to go to get the upper implants. So what I did was I sent the surgeon a little note about doing a little tuberosity reduction, just to make my life easier and have a better fitting denture and not a thin area that's going to crack. So when he did the surgery, for the implants, he also did the tuberosity reduction.